Good evening and welcome to Queries. I'm your long-lost prodigal host, Brian Kimmett. It's been a while since I've sat in this chair. And tonight we have three very special guests, and we're going to be talking about, honestly, a very serious topic, and one that, frankly, breaks my heart and the hearts of a lot of people. And this is in relation to the Ohio House Bill 68, as well as Governor DeWine's executive order that came after his veto, and of course then the vote to override the governor's veto. So the three guests that I have with me tonight, so I have Siobhan Boyd Nelson, and she is with Equality Ohio. Welcome to the show. Thank you for coming from Columbus.
Thank you.
And then Dr. Heather Stewart. And Dr. Stewart is an expert in transgender care for both adults and youth. And so she'll be providing us with sort of the medical background that we are definitely going to need. I'm definitely going to need. And then we also have Bobby Arnold, who is the trans representative for PFLAG Dayton. And obviously someone that, frankly, this is going to impact in very big ways as far as this goes. So welcome to all of you. Thank you for coming and especially for talking about something so incredibly serious and so incredibly personal, especially in your case.
Thank you.
Mm-hmm. Thank you. So to start off with, we're going to go with sort of the medical piece first. Let's start with medical.
Okay. And
basically, in terms of what I want to discuss is dispelling all of the myths, all of the lies, all of the obfuscations, all of the omissions and sins of commission that have gone on during this particular debate. Because frankly, most people don't even begin to understand what actually goes into gender affirming care. So I guess to sort of start things off, and pardon me for any ignorance that, I may, because I'm learning as much as I can in a short amount of time. So first of all, in terms of gender affirming care, myth number one that I want to dispel right away: children are not having their genitals mutilated in any way, shape, or form within the state of Ohio, let alone the country. Correct?
Correct.
So let's imagine I'm a parent. My child comes to me. And, they say, Dad, I really think I'm a boy, or Dad, I really think I'm a girl. What process is the parent and the child going to go through once I actually seek out medical advice and a medical opinion? What is the process that is gone through?
So the process is actually based upon standards of care. That is another point of misinformation that is out there, is that this is all experimental, that there's no standards. So there are standards of care. And so when those families come to their pediatrician, oftentimes that is then the case where that pediatrician may have some experience in offering advice on how to support their child, and listen to them. And really that's key. That's key, is allowing your child that safe space where they feel loved. They know that their parents love them. They know that they're cared for, and can just express how they're feeling and start to really explore those feelings, and know that as they're doing that exploration, that it's a safe environment to do it. And so that can be a place where parents are really looking for a lot of support, because they've heard that if they let their child have that exploration, that it may be negative. They want to do what's right by their child. When they get to one of the centers in Ohio, the different programs that are available, there's an assessment process that occurs with specialists who have experience with gender diverse youth. So not all youth who are gender diverse have the medical term dysphoria or gender dysphoria, but we know how to assess that as medical doctors, as well as mental health specialists who know how to assess for gender dysphoria and gender diversity. And depending on the age of the patient is what then happens next in terms of what that care looks like. So when we have minors who are under pubertal status, because there's not one age that everyone goes into puberty. So we do have to assess for where are people in puberty. And so when people are prior to pubertal status, there is no medical intervention. It is all support and love of their family, having their pediatrician do their well visits, encouraging activity in the school and with other kids and socialization and all of that normal healthy development that occurs. When patients are at the beginning of puberty, in the early stages, that is when we start talking about puberty blockers and what benefits may occur with puberty blockers, as well as what are risks. Anytime we talk about medications, it's always both sides of that. What are the benefits? What are the risks? What are the potential side effects? And so puberty blockers are discussed. Not every family, not every patient who is in that stage of puberty may decide that they need or want puberty blockers. Oftentimes, though, what is the case, and we have this, multiple studies have shown this, it's more a lack of access to puberty blockers when people could have used them than it's a lack of need.
And just a quick question to interject. I know that there's an awful lot of chatter out there or a belief that puberty blockers are, if your puberty is blocked, it's irreversible, it causes irreversible damage, it causes X, Y, and Z. Is that true?
That is not true. In terms of puberty blockers, these are medications that have been around for decades that are FDA approved for the use in patients, younger patients who are experiencing early puberty. So when you have a 5 or a 6-year-old who is experiencing puberty, we consider that early puberty. The term for that is precocious puberty. We use these medications in those children to then halt puberty until they reach an age where it would be appropriate to undergo those changes of puberty. And we have all of the safety and the data regarding use in that population. And so the use of puberty blockers in children with gender dysphoria is an off-label use of that medication according to its FDA indications. And what it does is it halts puberty where it is. So it does not cause a regression of puberty. It will stop things where they are. And it allows time for that child to continue to socialize, continue to work with their mental health providers, and that again is the standard of care, and really determine what is the best option for them. Some patients who start puberty blockers will actually determine to stop their puberty blockers and allow the puberty that their body produces to resume and go through that. And I consider that a win for that patient because that is the role of that. Other patients who are on puberty blockers will stop that puberty blocker after they start the hormone for the puberty that they feel is right for their body. When I say they feel right, this is that expression of their gender identity, whether they're masculine or they're feminine. So that's how we're determining what is the right hormone for that patient.
So, and again, I think there's some sort of, I think there's a lot of misconception out there that, oh, you've got the puberty blocker and now you're going to, inject this kid with either, estrogen or testosterone, which that's, according to what you said, absolutely not the case.
No. Again, there is a process to that. Not every patient who starts a puberty blocker will start hormones. And the term that's used as we talk about House Bill 68 is cross-sex hormone therapy. That's not the term that we use in the medical community, but that's what the language that you'll see there.
What is the actual correct term, just in case someone who's in Ohio government is listening, which I doubt, but.
Medically necessary gender-affirming hormone therapy would be how it is documented in the medical community.
Gotcha. Because again, heaven forbid we use proper medical terminology. So now the other thing that you said is that, as this child is, let's assume again that they've got the puberty blockers, they're receiving, throughout all of this, they're receiving mental health support, correct?
Yes, they're receiving mental health support and counseling. If there are other conditions that they are dealing with, be that anxiety, depression, they're receiving ongoing support and therapy for that. That might include medications, it might not. There's oftentimes family therapy that's going on if the parents feel that they have that need. Parents are different, and so not all families have that need for family counseling and therapy. Oftentimes there are support groups that exist at many of the children's hospitals that the youth are going through as a part of the process. and again, that socialization that's
Mm-hmm.
occurring in the home, in the schools, and the community.
And I guess that's one of the important things, is that this is a process that involves the whole family. This is not a,
Correct.
the kid is walking into, children's hospital and like, I feel like I'm a boy or a girl, and then, oh, we're just going to give care to them regardless of what the parents want. And
So you are correct. It starts with the child because the child is the one who knows who they are on the inside.
Yep.
They are the ones who are experiencing their gender. But when it comes to any medical interventions or decisions that are made, that is made with the family. And those parents and guardians, as that legal guardian status, are the ones who ultimately decide yes or no on puberty blockers, on hormones, on any intervention for a child who is a minor in the state of Ohio. Regardless of what that treatment is, their parents are involved and consenting.
and there's no jumping the system. This is a very well laid out. This is how this is going to go, and this is the path we're going to follow. It's not just a, hey, get out the magic 8 ball and let's figure out.
Correct. There is definitely a standard of care that is followed in all of the institutions here in Ohio that treat minors. And one of the other things that I think is important to point out is when families aren't ready, maybe the child is, and that happens a lot where that child or teen is ready, they've done their own research,
Sure.
and they can sit down and give you a book about that hormone. But if the guardian is not ready and not on board, those patients do not receive those medications. So it has to be with the consent of their parent. And that is a standard here in Ohio, and we do that for every medication. And we then work with those families. We continue to help them support their child and even empower that individual, that teen, to know, you know what, your parent's not ready for that, but that means that, as you're aging and maturing, we're going to continue to support you. And this gets to be your decision when you're older. And so if this is something that you continue to express a need for, when you're old enough to do it on your own as an adult, then that will be your opportunity. And let's talk about that and how we can consider that with your parents. And I have lots of parents who say, I don't feel comfortable making that decision because what if they regret it?
Sure.
And then I made that decision for them. I would feel more comfortable if they made that decision for themselves.
Sure.
And I don't fault them for that. That is their child, that is their family and their process. And so we just continue to support them through that. And I do have that conversation a lot, that this is individualized, but it's based upon standards.
And I think that, one other question that just popped into my mind, because I made the, at the very outset, asking if, there's, children are having their genitals mutilated, as the opposition would refer to it. Is there ever a scenario where, a child, for their own safety, for their well-being, that with their parents' consent would have surgery? I mean, I would imagine that would be shockingly and vanishingly rare, but is there ever a case where, someone below the age of 18 that we need to do this because XYZ?
Genital surgeries on minors do not happen in the state of Ohio.
Period. It's not even a consideration, not a part of the
No.
standard of care.
They're not a part of the standard of care, and they have not occurred in the state of Ohio. It is not an issue that we have had to deal with. There are no providers in the state of Ohio who are offering genital surgeries on minors.
So there's no cottage industry of, drive-through surgeries and whatever the fever dreams of the opponents to this. It's just shocking, the ignorance. Now, Bobby, obviously, you've gone through all of this. So when did you know that your gender didn't match your biological sex? At what age did you realize that?
I don't remember a time where I felt in alignment with my body. I don't remember a time where the boy things was natural to me. I've always drawn to the feminine things, Barbies, hairbreadths, girls' clothes. It's something that I've just always was drawn to naturally.
What So what was it like when you were able to receive gender affirming care? I mean, what was that like for you when people weren't pointing at you and, oh my God, you're weird, or, what have you, but you got the support that you needed? How did that feel?
It was like waking up to a whole new life. I had hope for once in my life, confidence in who I was, that, somebody actually sees me for who I am and is willing to help me be that person. It's totally life-changing.
I mean, in my mind, I can't imagine a greater hell than looking in the mirror and seeing something that I'm really not, and having to somehow process and deal with that. I can't even imagine what that did to you. I can't even.
It's soul-crushing. You internalize so much hatred. I live in a rural area, so I am inundated with all of the hate and the intolerance that our community has. And you can't help but internalize that.
Sure.
I know how I feel, but I'm constantly told that I'm an abomination for feeling that way, that it's a sin, that I should pray this away, and you just can't, it just doesn't go away.
Right.
It's not something that you can be cured of, it's who I am.
Mm-hmm. Now, did you transition as a teen, or was it later in life that
I was in my mid-30s.
Your mid-30s?
When I came out, I was 35, and then I started on hormones shortly before I turned 37.
So we've dealt with, from the medical standpoint, we've dealt with youth. How does care for an adult who is transitioning, how does that differ from what, the care that is associated with a youth?
So adult care is based on the informed consent model, and again, that's based on the standards of care. So some adults will come into medical care from the mental health aspects. Sometimes adults will seek out a therapist or a mental health provider to help them understand more about what they're feeling and what they're experiencing. Because again, often this isn't a conversation that's had, or when it is had, it's a very negative connotation, and you can internalize that.
Sure.
And so patients may come through medical from a mental health provider, or they may seek out that medical provider on their own, having done their own research and their own kind of exploration of who they are and what their needs are. That medical provider is going to do an assessment, again, looking for is this gender dysphoria? Are there other medical conditions? Are there other mental health conditions? Anything that might also need treated at that time? And then talking to that individual about what medication options are available for them and what might be best. And then the timeline for that is very individualized, because depending on that initial evaluation and screening, if there are health conditions, if there are mental health conditions that might be precluding a safe start to those medications, then we would address those things. But very much that is in the primary care role for the majority of adults. They're seeing either, their family medicine, their nurse practitioner, their PA, and that is something that is often handled in the primary care office. There may be specialty clinics. Not everyone's primary care provider has been trained on gender care. It is becoming a more common training in medical schools, as well as a requirement for American medical boards here in America to know how to provide care and to understand more about hormone management. But certain aspects of hormone management have been around for a while.
So this is not anything where it's like, again, fly by night. We're going to make up the rules as we go along. This is, again, there is a set standard of care that is followed to the letter, and no deviation. You're following the standard of care.
There's a standard of care, and there are protocols. As with anything in medicine, there's a range, right? So what is the appropriate range and which protocol? But University of California, San Francisco has guidelines that are available for everyone. We have Fenway Health, we have Cal and Lord, we have large organizations that freely make available their guidelines and training materials to help support primary care offices, because again, this is primary care in adults.
And we're going to get in the second half of the show, we're going to kind of get into what's, gone on at the State House and through the governor and his executive order. But from what I understand, with the executive order, they've just completely superimposed the way youth care is handled, applying it now to adults, and they're setting up all sorts of rules and regulations that you have to have this, and this in place. So that would preclude an awful lot of primary care physicians from really doing anything, correct?
Yes, when we look at the proposed rules, they are adding layers of complexity to care for all Ohioans, including adults, that the system is not set up to handle. We have shortages of the specialists who frankly don't have a role in adult care for the wide majority of Ohioans and transgender and non-binary adults in the United States, just in general. But
so it basically this kind of smacks of what states would do with putting onerous regulations and stipulations on like abortion clinics, for example. Just this ridiculousness that doesn't apply in any way, shape, or form. And they do it because they know that no one can meet those particular standards. So I'm going to assume that that's exactly the point behind the executive order, is to make it so onerous while making it look like we care, but we're not going to be able to provide care because of XYZ. So I mean, I don't even know how to react, because this is just there's so much bigotry and hate behind this, under the guise of love and protecting kids and apparently even protecting adults from themselves, that kind of nonsense. And just on a personal level, doctor, how does that make you feel? Everything that is, they're denigrating your specialty area. How does that make you feel?
It's a very loaded question. I have over a decade of experience, and it's very difficult to read rules that are excluding my expertise and my knowledge, that aren't following the standards of care that I have followed for all of these years. And it's painful to then have those conversations with my patients. And that is the hardest part, is actually to see the impact directly multiple times a day, every day.
And in essence, while all of this has been going on, have you had to begin to lay the groundwork that, we may not be able to continue care?
I would say the conversations increased starting on Trans Awareness Week, when conversation hearings began in the Senate. The conversations became much more concrete about what we were looking at and how quickly this was proceeding.
What is I'm trying to think of what is the credo that doctors do no harm?
Yes.
And the state is basically forcing doctors to not practice, which causes harm to their patients. And it's just, I don't mean to laugh, but because it's so, my brain refuses to process how ridiculous this whole thing is.
And I will say, one of the comments that are made often by lay people is, well, if you don't do anything, then how are you doing harm? But it's very clear harm when you're not allowed to do anything. It's not neutral.
Right.
It's not neutral at all.
It sounds neutral and it sounds wonderful, and let's put it on a placard, and it rolls right off the tongue, but it's just it's not. And I can't even fathom it. Well, we'll halt there in terms of from the medical standpoint, and we're going to get into the political piece of it that will also still involve the medical piece of it. Mm-hmm. We're going to conclude here with part one of our show, and when we come back next week, we're going to pick up with the political side of this and the implications of what's actually being done. So thank you for watching episode one, and we look forward to seeing you for episode two.